So, with this AMBITION trial that you're principal investigator on, I mean, how did you guys, that's pretty, yes, ballsy to do a randomized control trial between, laser, Arion laser specifically, and angioplasty alone. And I think that's a, pretty interesting process. How did you decide to do that trial? And then give us a little bit of details on that too.
Of course. Thank you for asking. I mean, so, the reason that we decided to do it is because we basically needed to shit or get off the pot, to be frank. And what I mean by that is every meeting, I go to, of course, my vascular meetings. I go to my cardiology meeting. I go to SIR. I have friends in all these areas. I speak at these meetings. And, I'm just sick of this conversation about atherectomy. Do the data and answer the question, or stop talking about it. And that, I don't know, I've got a few colleagues who are like me as well, who feel the same way, because it's the same thing over and over again. Somebody will come up and be like, I use it, it's amazing, look at all of my patients, look at this data, which is either case series or single arm interventional or something like that. And somebody invariably will come to the mic and be like, but there's no RCT. Then they start fighting about overuse. I say they because it's not, it's usually, and
it's everyone.
There's clearly an undertone. So it needs to be just put to rest. And the way that we do that, just to begin with, is we need to start somewhere. And we decided that this made the most sense because a lot of people do already use the laser. It is already FDA approved. And the clinical need right now, which is really what should drive all science, the clinical need is for something for below the knee patients. In the United States, we have a ton of stuff for above the knee. Okay, everything. Actually, for above the knee. Below the knee, we have Shockwave now. We have the Serenator balloons, and we have atherectomy. Now, recently, in New England Journal article, bioabsorbable stents are on the market now, but that's a treatment. That's not a prep, right? And we need to, and treatments don't work without good vessel prep. Everybody knows that too. So what are we going to do to get a nice luminal gain that's going to not recoil, that's going to allow me to get this laminar flow for at least a year, so that the wound on this patient's foot can heal. That's the game. Because I tell people when I talk about this that the patients even of today, even from when I trained to now, just a decade ago to now, are different. People are full of calcium. In the PROMISE trial, which was the DVA trial that I was a part of, up to 25% of our patients had full-blown end-stage renal disease, 50% had CKD. That's the new world order. And so if we don't figure out how to deal, we can't just go excluding these patients from trials, right? We have to say because that's half your patients. So we need something for below the knee. And instead of going in and inventing something new, why don't we look at what we currently have and see what's best for what patients at what time? And so with that in mind, we said, let's see if laser atherectomy would be the right one to choose. And I personally think it is, because it's the one that has minimal to no embolization, minimal to no dissection. People are familiar with it. It is FDA approved. And in our vascular surgery world, we use the laser already for other stuff. When we do fenestrated grafting and people's hands have been on it. So technically understand it. And so POVA is really the gold standard for below the knee right now. Even unfortunately, the Saval trial, which was the drug-coated balloon trial from Boston Scientific, didn't show. But, as you look at that, you think was it really true that it didn't show, or was it more the endpoints were not perfect? We don't know.
Sure.
So
sure.
To that end, we wanted to design a trial where we really looked at true clinical endpoints.
Good.
And made a trial that one, answered the question about atherectomy, two, gives us something that we clinically need, three, brings our community together so we stop fighting about something stupid, right? And also answer the overuse question, because now we'll know where it's good for. And four, and most importantly, be able to prep a vessel in a way that the treatment that you're going to put in actually is durable to some extent. And that's how we came up with this trial.
That's great. And then, I mean, at this point, how far into the trial are you? I believe you started this year, correctly?
We just started up. We have quite a few sites, actually. And we just started up with our first randomized patient a day and a half ago.
Nice.
So yay.
All
Yes.
right.
So that's
We
good.
are right on the cutting the
Yes.
cusp of this,
Yes. Yes.
And how many you guys are hoping to enroll about 200 patients, is that right?
Yes.
Or what? Yeah. Okay.
And what we're actually doing is, so the way that we're setting it up is we're kind of doing a registry in combination with the RCT. So we have
Oh,
very
nice.
stringent
Okay.
criteria. Like we're not messing
Okay.
around here because the
Yeah, you're
overuse
making this
thing is
right.
big.
Yeah.
Yes. Yes.
Okay.
And
Good.
even the co-PI situation, I'm a vascular surgeon, my colleague, Interventional Cardiology, on purpose, because we want to say like the community's coming together to answer this question for the patients. And so, and he brings his knowledge about that world and what they need, and I have my knowledge about the vascular surgery world. And what happens a lot of times is because our criteria is so stringent, and not stringent like to exclude patients to cherry pick, actually not at all, quite the opposite.
Yeah.
We want to make it as real world as possible. So the criteria is such that like the lesion length has to be specific. And we're not saying you use it for everything. We're trying to say when you do. And so
Exactly.
if you do have a patient that doesn't fit the criteria for the RCT, but has an SFA lesion, for example, that you want, because this is a below the knee trial, obviously, but has an
it's nice.
SFA lesion.
Can you collect the data? Yeah, the registry.
The registry. So we'll allow you to use the laser. We'll allow you to be a part of the trial, but the registry arm of it, so you get to use it. Everything would already be set up. So it's not going to waste a doctor's time that they consented and that they talked to the patient about it, because patients get excited and then you don't want to be like, oh yeah, we didn't because, you didn't fit. So doctors, and then the registry thing, yeah, will allow us to, mine data and allow the world to mine data that's going to be available to figure out if they want to answer particular questions. Like maybe if you have two lesions, SFA and something in the AT, like do you have a different outcome than if, who knows? So that's what the registry is for.
I love it.